right, we're going to get started in just a moment. A few announcements before we begin. I believe that some of the slides are still not posted on Courseworks. We're a little delayed because our administrator is on jury duty, but we are working to rectify that, so you should have them shortly. Also, people who are in Dr. Natalie Yip's small group, you're going to miss her today. Dr. Yip has received a teaching award from the medical residents and will be giving grand rounds today. So Dr. Keith Brenner will be taking over her section. He's terrific as well. I'm delighted to welcome back Dr. Alan Borshuk, who you've met a couple of times, and to introduce you, those of you who are not in his small group, to Dr. David Lederer, who's an associate professor of medicine in the Division of Pulmonary Allergy and Critical Care. Dr. Lederer is also one of the co-directors of the Interstitial Lung Disease Program and is one of our transplant pulmonologists. He is the former director of this course, in fact, so he's a very experienced teacher and lecturer, and we're delighted to have him here today to talk about interstitial lung diseases with Dr. Borshuk.
Good morning. Can you guys all hear me okay? We're good in the back? All right. So in the next 2 hours, we're going to go over interstitial lung disease, which is something I kind of live and breathe, and so I always need to step back and make sure I'm tackling this particular topic in a way that's understandable to you guys, because I know you're being hit with a lot of new information every day in medical school, and we're about to talk to you about some very kind of poorly understood, weird group of diseases that have a funny name. And I'm going to try to make it as simple and straightforward for you as possible. These are our disclosures. I do consulting with a number of pharmaceutical companies related to clinical trials in idiopathic pulmonary fibrosis, including consulting for a couple of companies for who they've received FDA approval for a couple of drugs that we're going to talk about. So I'm disclosing that to you. Dr. Borshuk has no relevant financial disclosure. So we're going to go over some definitions and pathology, some pathophysiology, a very complex classification scheme that we're going to try to simplify for you, approach to the patient and management, and all of that's in the first hour. In the second hour, in order to try to make this even more clear, we're going to go through a few cases of different patients presenting with these diseases. So I'm going to take the liberty of doing a couple of Dr. Borshuk's slides. As you already know, you've begun to learn about different disease states in the lungs. You've learned about diseases that affect the airways, such as asthma and bronchiectasis. You've learned, Bill, have they learned about pleural disease from you yet? So you've learned about the pleural diseases. You will have, or maybe you did or will learn about the vascular diseases in the lung. So if you remove the airways and you remove the vasculature and you remove the pleura, what is left? Well, what's left is your lung, right? Because what's left are your alveoli, your air sacs, or the walls of your alveoli. And that's the interstitium. And interstitial lung diseases are diseases that affect that part of your lung, or essentially affects your lung. So it's really lung disease. Is that fair? No? Often, interstitial lung diseases have fibrosis, collagen deposition, which is shown here in the upper left. See that blue staining material is collagen. Or they have inflammation, usually mononuclear cell inflammation. You see all of those purple staining dots in the lower right-hand corner. That's chronic or mononuclear cell inflammation. Or often they have both. And I'll point out that this is a really healthy, normal-looking lung with thin alveolar walls, normal air spaces. And you can imagine how easy it must be to take a breath, because of that normal, compliant lung, you just have to have a little change in transpulmonary pressure, and the lung expands, so it's easy to breathe. And you also can imagine, within all the little millions of microscopic lung units, it must be very easy for your lung to match alveolar ventilation and alveolar perfusion within and across all of those lung units to achieve normal VQ matching, and therefore normal gas exchange at rest. And the alveolar walls are thin, so that during exertion, when you only have a quarter of a second of transit time of that red blood cell passing through the pulmonary capillary, even during that quarter of a second, it's easy to get oxygen molecules across that alveolar capillary membrane. There's normal diffusion, so there's normal gas exchange during exercise. It's easy to breathe, normal gas exchange at rest, and during exercise. But when you look at the pictures on the right, fibrosis and inflammation, you can imagine that none of those things are true. You probably have to generate much greater transpulmonary pressures to take a normal breath. Or another way of saying that would be at resting transpulmonary pressures, your lung volumes are probably going to be smaller because your lungs are stiffer when they're full of scar tissue or inflammation. You're going to have a lot of EQ mismatch because of all this very abnormal lung architecture. How could you possibly have normal compliance of those little microscopic lung units? So you'll have lots of areas of low VQ. And of course, you'll have a lot of diffusion impairment. So you'll have both resting and exertional desaturation. Did everything I just say make sense to you? Silence on a conference call means yes. Silence in a classroom means no. Okay. So let me go through what I just said. So you learned a bit about mechanics last week from Dr. Pullman and Atkinson. When we talk about lung mechanics, what we mean is that there's either, we're talking about airflow through the airways, or the compliance of the lung tissue, or the compliance of the chest wall. And in the interstitial lung diseases, the predominant problem is that the lungs are not compliant. What you're looking at are pressure volume curves, or hypothetical curves, with pressure on the x-axis, volume on the y-axis, and you all understand what total lung capacity is, right? Yes? Okay. And you can see in the normal setting, and if we focus on the left-hand part of the curve, you can see this pink straight line. That's the pressure volume slope, or the compliance of the lung in the normal setting. But when there's scar tissue or inflammation in the lung, that curve is shifted down. So that at a given transpulmonary pressure, for example, and these are not real transpulmonary pressures, but at a given pressure, you'll have a lower lung volume. Everyone follow that logic? So lungs with inflammation or scar tissue in them, at a given transpulmonary pressure, the volume will be lower. So if we were to try to find out if a patient of ours had interstitial lung disease, one clue could be a reduction in the volume of the lungs at resting transpulmonary pressures. You guys know what the volume of the lung is at resting transpulmonary pressure? What that's called? It rhymes with FRC. It's FRC. Good. It's excellent. So interstitial lung disease leads to a restrictive ventilatory defect, which is a reduction in lung volumes, as you learned. And of course, as you learned, we officially define that as a reduction in total lung capacity. Of course, we measure it by measuring forced vital capacity in a body plasmithograph or by nitrogen washout or helium dilution. And then we can measure all the other volumes and get your total lung capacity. But on spirometry, we will often see a low FVC, that's forced vital capacity. And of course, that's all the gas you can breathe out after a maximal inhalation. We'll also see a low FEV1, but in most cases, we will not see airflow obstruction. And airflow obstruction, as you recall, is a reduction in FEV1 to FVC ratio. So characteristically, we'll see low FVC and a low TLC with no airflow obstruction. Everyone on board so far? Right? So you have inflammation or scar tissue. We haven't even talked about what the disease is. All you know is there's inflammation or scar tissue in the lungs. And physiologically, we observe a restrictive ventilatory defect. And now you understand why. Good. Questions so far? It's all clear? Okay. So the second physiologic concept is gas exchange, and you learned a lot about gas exchange. Of course, when we talk about gas exchange, we're talking typically about oxygen transfer in the lung and focusing on causes of impairment of this process, impaired gas exchange. And you know the three causes of impaired gas exchange, or three types of impaired gas exchange, are VQ mismatch, predominantly areas of low VQ, right to left shunt, and diffusion abnormality. Now, I will tell you that in contrast to folks who have COPD, which I think you've learned about, people who have interstitial lung disease typically have much more severe hypoxemia, much more severe. They often require a lot more oxygen. Hypoxemia is very common. The characteristics of hypoxemia in interstitial lung disease that are clues, important clues, are that it gets worse as the disease progresses. And that's true for many of these chronic lung diseases like interstitial lung disease, COPD, cystic fibrosis. But the scope and the magnitude of the hypoxemia is much more profound. They might need a little bit of oxygen sometimes early on in the disease, but at the end stage of the disease, it could be 10 liters, 15 liters, or more that they need. Very severe. The other characteristic is that it gets worse when people exert themselves. When they walk upstairs, when they walk up a hill, when they exercise, when they walk around the room. And that's the first thing that people notice is, oh, I'm short of breath when I exercise, or often what I hear is a short of breath on vacation, because I'm sedentary, but then I traveled somewhere and I was walking around and hiking and I couldn't catch my breath. And that's actually a very common history in the office. And the reason that the hypoxemia gets worse during exercise is because of the diffusion impairment. The causes of hypoxemia, the major reason that people with interstitial lung disease have hypoxemia is VQ mismatch, areas of low VQ. That explains most of the resting hypoxemia. In fact, it probably explains almost all of it, according to Peter Wagner and John West from papers years ago. The diffusion abnormality, which is what most medical students are taught is the cause of hypoxemia in interstitial lung disease, is not really a major contributor until you exert yourselves. And then that transit time through the pulmonary capillary gets shorter and shorter, and there's simply not enough time to pick up all the oxygen during that quarter of a second of transit time. How's that sound? Straightforward? Too simple? Too obvious? Okay. Have you guys seen this slide? A little bit? Okay. You guys understand it? You're good with it? Should I go over it a little bit? It helps illustrate what I just talked about that diffusion problem. This is the time in seconds let me start again. So imagine you're a red blood cell in the pulmonary artery and you're about to enter the pulmonary capillary, and of course you're really excited because you're going to get to pick up all that oxygen, and you know that you have about 3/4 of a second to get to the other side, right? So you're going to travel through that pulmonary capillary. Oxygen is diffusing across the alveolar capillary membrane, and after 3/4 of a second, which is the usual pulmonary capillary transit time, you are able to pick up 100% of all the possible oxygen you could. Okay? Just as an arbitrary percentage of what you could do. In fact, you achieve that within about 1/4 of a second, and then you have another 1/2 second to kind of lay back and chill out in the alveolus. Now, if you exercise, you only have 1/4 of a second because stroke volume increases, heart rate increases, and the transit time is just shorter because blood's flowing faster through the lung. And even during exercise, you achieve 100% of all the possible oxygen transfer that you could, assuming that the diffusion in your lung is normal. Everyone follow? It's pretty straightforward, right? Now, if you're an elite athlete, you might actually be able to move less than 1/4 of a second and fall off this diffusion curve. I'm not going to talk about it, but that's the diffusion impairment you see in severe exercise. Severe exercise, yeah. Now, if you have an abnormal lung with an impaired diffusion, then this may not be the slope of oxygen transfer. It may be much slower. You see the slope of this line is a measure of diffusion. And even after 3/4 of a second, you may or may not reach 100% saturation. And when you exercise, you won't even have enough time to transfer much oxygen. Does that make sense? Okay. So we talked about mechanics and we talked about gas exchange. Those are two major physiologic principles in lung disease and how they relate to ILD. The other two, at least that I talk about, are ventilation and vascular changes. Now, in contrast to COPD, alveolar hypoventilation is actually quite uncommon in most interstitial lung diseases. It happens sometimes, but almost never happens. So that can be surprising to most people. But most people, even with fairly advanced interstitial lung disease, actually have alveolar hyperventilation, not alveolar hypoventilation. The reasons that people have alveolar hyperventilation include hypoxemia, but predominantly it's abnormal mechanics and load. Vascular disease is actually quite common. If you were to biopsy the lungs of people with inflammation or scarring, there's often a bit of intimal proliferation, medial hypertrophy, and people can develop pulmonary hypertension. It is often not very severe, although in some cases it can be, and that then leads to the right ventricular changes in heart failure. So does anyone have questions about what I've just talked about, the underlying physiologic issues? What's so funny? And you guys are really serious. Okay, yeah. So why do you get vascular changes in interstitial lung disease? So it's not perfectly clear. There's a widespread theory that it's related to hypoxia, alveolar hypoxia, and chronic vasoconstriction, and When people exert themselves, they desaturate, and then they have more alveolar hypoxia, more vasoconstriction, and there's some kind of promotion of pathobiology in the vasculature because of that. But it's also possible that it's simply part of the disease process, and we simply don't understand it well enough.
What do you mean specifically when you say respiratory mechanics and load?
Good question. What do I mean by respiratory mechanics and load? So by mechanics, what I mean are that or actually by both, is what I mean is that you have to work extra hard to get things done. So if you have stiff lungs or abnormal airways or an abnormal chest wall, then the load imposed on your respiratory muscles is much higher, as people have to work much harder. Yes?
When you say right to left shunt as a cause of hypoxemia, do you mean right to left shunt in the heart or a shunt of blood through the lungs that's not picking up any oxygen?
Good question. Right to left shunt can refer to either intrapulmonary shunting or right to left shunt through an ASD, VSD, or PDA. Since I'm a lung doctor, it's often lungs, but it definitely can be both. And most people who have impaired gas exchange don't have a right to left shunt. And most people who have impaired gas exchange also don't have a diffusion impairment. And the only way to really know if someone has VQ mismatch, right to left shunt, or diffusion impairment as a cause of their impairment of gas exchange, meaning as a cause of their elevated AA gradient, is to understand the disease they have and understand what the contributors to impairment of gas exchange are in that person. The things that typically cause intrapulmonary shunting, right to left shunt, in people with lung disease would be those who have an alveolar filling process. So those would be people who have severe pneumonia where there's lobar consolidation and there's blood coursing through these alveoli full of infection with no gas in those alveoli. That'd be right to left shunt. People with the ARDS, has that been covered yet? So people with ARDS, with alveolar filling, with this exudate-rich fluid, severe pulmonary edema, be uncommon, but could be, since it's ARDS is a type of pulmonary edema. But severe hydrostatic pulmonary edema, the lungs simply full of fluid, could also do that. And then shunting through arteriovenous malformations and other things, hepatopulmonary syndrome. But most people that you encounter in this course who have impaired gas exchange will have impaired gas exchange because of low VQ. Other questions? Okay. So I've given you a very broad overview of the pathophysiology of the disease and what happens when there's inflammation or scar tissue in your lungs. Now, take that as a foundation and let's build on it. We're going to translate this a little bit clinically. The problem that most medical students, and in fact most doctors who deal with these patients, have is that the nomenclature for the clinical entities that we encounter is extremely confusing. And it's an alphabet soup. Now you can see here, there's some abbreviations here, IPF, ILD, IIP, NSIP. It took a very long time to get the letters to line up like this. This is an introduction to the alphabet soup of the interstitial lung diseases, the classification scheme. It turns out that until recently, there actually was no good working, I wouldn't say it's operational, it's not, but conceptual definition of interstitial lung disease. This was published a year or two ago now. ILD can be defined as the following: the presence of acquired cellular proliferation, cellular infiltration, and/or fibrosis of the lung parenchyma not due to infection or neoplasia, at least as we know it today. And that kind of makes sense from what I've told you, right? That there's inflammation, which would be cellular infiltration, fibrosis. And some of these diseases have cellular, like smooth muscle cell proliferation and other things. So let me introduce the terminology. So I've defined the interstitial lung diseases for you, ILD. You may come across another term, which is diffuse parenchymal lung disease, or DPLD, which is exactly the same thing as ILD. Believe it or not, after decades of having ILD as a kind of overall umbrella term for the category of these diseases, a second term was introduced, DPLD, which is the same exact thing as ILD, except it's one letter longer. Now, within the world and the family of interstitial lung diseases, there's another term, which are called idiopathic interstitial pneumonias, and I apologize, I didn't make these up, that I'll introduce to you on the next slide. That's a subfamily of diseases. These are diseases with inflammation or scar tissue in the lungs for reasons we don't understand. Therefore, they are idiopathic interstitial pneumonias. Okay? Within the IIPs, there is one disease called idiopathic pulmonary fibrosis. Anyone heard of that disease? One person, two people. Idiopathic pulmonary fibrosis, or IPF, which is the most common idiopathic interstitial pneumonia. We're going to talk a little bit about it. And then you'll also come across a term, pulmonary fibrosis, which is not a specific term at all, simply means scar tissue in lungs, of course. And we often use the term pulmonary fibrosis to refer to any form of interstitial lung disease which has scar tissue in the lungs, but it's not really a true medical term. Okay? That's like a little background slide that you can refer to later to try to clear things up. Now here is one representation of the classification scheme that we use for these diseases when people show up in the office and are found to have an interstitial lung disease. The family of diseases probably has over 100 different kinds of disease. And there are 4 categories. On the left are diseases of known cause or association. And I'm going to I'll give you a list of those in a little bit. But those would be things like autoimmune diseases. I don't think you've had autoimmunity yet too much, right? But things like lupus, scleroderma, rheumatoid arthritis, where there can be inflammation and scarring in different organs, including the lungs. Occupational diseases like asbestos exposure, coal workers, silicosis from people who do sandblasting, drug side effects from chemotherapy, etc. We'll talk a little bit about these. So those are the diseases where we kind of know what the trigger might have been. In the second category, I've already mentioned to you, are the idiopathic interstitial pneumonias. These are diseases with inflammation or scarring in the lungs for reasons we don't really understand, the IIPs. And you would think that those two families, the diseases of known cause or association and the diseases of unknown cause or association, would be the entire universe of all of the interstitial lung diseases. But we have 2 more categories because we make it complicated. So the third category are diseases with granulomatous inflammation. Almost exclusively, this category is sarcoidosis, which we'll talk about later. A related entity, it's not even a related entity, another entity, hypersensitivity pneumonitis, in this schema is listed in the granulomatous category. I don't put it there. I actually put it in the known cause or association category, and we'll talk about it. And then in the last category are the other forms of interstitial lung disease. As soon as I say you don't need to know them, they will show up on your test, so I'm not going to say that. Oh, this is a tough crowd here. But they are diseases like lymphangioliomyomatosis, pulmonary Langerhans cell histiocytosis, eosinophilic pneumonias, and other things. They're weird things that I don't understand. I mean, I see patients with this, but we don't understand these diseases very well. So let me come back to this, the idiopathic interstitial pneumonias. This is actually a little bit outdated, but that's okay. The most common form is idiopathic pulmonary fibrosis, or IPF. We're going to talk about it. There are other forms of idiopathic interstitial pneumonia that we can figure out, we can learn about when either through a CAT scan or a biopsy. I'm going to show you what some of those look like. Okay. So people show up. Usually they're short of breath with exertion. It's been going on for 6 months, a year, 2 years. They often have a cough, and we do a full history and a physical exam, and we do a CAT scan. I'm going to show you some CAT scans. And very often between the clinical picture that I'm going to take you through in a moment and the CAT scan, we can come up with a specific diagnosis. But in about 30 to 50% of the time, we can't figure out what's going on, and we need to biopsy their lung. We do a surgical biopsy. And we call this a CRP, or clinical radiologic pathologic approach. So the clinical picture. So I've talked about these diseases initially when I was talking about the physiology as all very similar. And that's because they all seem similar in many ways. They all typically have progressive dyspnea that's exertional in nature. They have often a non-productive cough, meaning no sputum production. We often hear crackles in the lungs, although we can certainly hear other sounds, and some people won't have crackles. They almost always will have, at least in more than mild disease, a restrictive ventilatory defect, reduction in TLC, and on spirometry we'll see a reduction in FVC. They often will have impaired gas exchange with low VQ and elevated AA gradients and desaturation during exertion, and they will almost always have abnormal lung imaging on CT. So there are many similarities, but there are also differences, and this is how we begin to sort out different diseases in different patients. Some diseases will also affect parts of the body outside the lung. Sarcoidosis, which you're going to learn about, can affect any part of the body. There are connective tissue diseases, the autoimmune diseases, that can affect joints and skin and the esophagus and muscles and your eyes and other organs. So we try to pick those up on the history and the physical and doing serologic evaluation. The actual pattern on the CAT scan can be extremely informative to the trained eye. And of course, blood work and pathology also helps us sort all of these things out. So I mentioned the diseases of known cause or association. I just want to talk about them briefly. So this is important because this is where your history and your physical exam become really important. And as you train and become better at figuring out which questions to ask and what parts of the physical exam to focus on when the patient presents with a certain complaint, this is important. So I ask my patients about amiodarone. You guys heard of amiodarone? Of course. So what do I ask my patients? Have you ever taken amiodarone? No. I mean, I do, but that's not the first question. My first question is, have you ever had any fast heart rhythms? Because patients may not have heard of amiodarone. They may not know the names of drugs they were on in the past. Have you ever had AFib or atrial fibrillation? Have you ever had your heart shot? Have you ever had ventricular fibrillation or been in the hospital where your heart stopped? So I ask questions like that, and then I say, did you get treated with a drug called amiodarone? I'm not sure. Well, they might have. Bleomycin and other chemotherapy. Have you ever had cancer? Have you ever had chemotherapy? Which chemotherapies did you receive? Nitrofurantoin, which now everyone's using for urinary tract infections, causes fatal lung disease. I think we should stop using it. And so I don't say, did you take nitrofurantoin? People don't remember that. Have you had urinary tract infections? Have you had kidney infections or bladder infections? Do you remember any of the antibiotics that you took? Did you take nitrofurantoin? And I'll mention the brand names. Direct thoracic radiation therapy can cause fibrosis. I mentioned the autoimmune diseases. And then I ask many questions about someone's prior workplace. Have they been in the military? Have they worked in construction? Have they, and then you have to ask people what they do for a living now. And then you have to ask them, well, what did you do before that? And what did you do before that? And what did you do before that? And I work backwards in time to figure out what jobs people have had and what potential exposures they may have had. At the bottom, these organic antigens are going to come back to us. But this is these are things that cause hypersensitivity, pneumonitis. Typically, this is a disease due to birds or mold exposure. I know that sounds a little funny, but indoor bird exposure or birds that are kept in cages, indoors or outdoors, can contribute in susceptible people to inflammation and scarring in the lungs. Again, we'll talk about it. Mold can also often do this, and at least it's more common than bird exposure. So mold in someone's home, where there may have been water damage, mold in a ventilation system, mold in hot tubs or humidifiers can be a cause of this as well. So there's a lot of relevant questions there. So when we have patients who show up with suspected interstitial lung disease, we do a complete set of pulmonary function testing. We do a high-resolution CAT scan. High-res means that the imaging is done thin. So 5 millimeter is standard. We do 1.25s. We do an inspiratory supine and expiratory imaging. Expiratory imaging can tell us about small airways function. And then the images are reconstructed using a high-resolution reconstruction algorithm that you don't need to know about. But most CAT scans are not done that way. So if you get a regular old CAT scan and ILD shows up, you have to repeat the CAT scan, do it a different way, because we get great detail using that high-res CT. We also do walk testing to see if there's desaturation. That can be very helpful to us. People who don't desaturate probably don't have a lot of ILD. People who desaturate a lot may have very severe ILD. By desaturate, I mean that their oxyhemoglobin saturation drops during the exertion. And we do an echocardiogram to look at right ventricular function. In addition to that history, and I skipped over physical exam somehow, but physical exam, we also do extensive laboratory data, and I think you have not done your kind of rheumatology section yet. But one of the major things we look for is rheumatologic disease. So we do anti-nuclear antibodies and a bunch of other autoantibodies. I don't know that every detail on the slide is important, but that's an important part of the evaluation. So we also look carefully at the hands, because I know this sounds funny because it's a lung lecture, but the hands are really important, and very often ILD docs can find abnormalities in the hand that point us towards specific lung diseases. So you guys know what this is? Clubbing, yeah. So clubbing, which is thickening of the proximal nail fold due to hypertrophy of soft tissues underneath, can be seen in idiopathic pulmonary fibrosis. Can also be seen in a variety of other conditions, including lung cancer, cystic fibrosis, and some non-pulmonary conditions. You guys know what that is? I should have put titles on the slides. What's that? So these are called Guttron's papules. They're shiny red areas on the dorsal surfaces of the joints of the hand, often seen in inflammatory myositis called dermatomyositis, autoimmune disease of the skin and muscles, and often the lungs as well. Anyone? This is called Raynaud's phenomenon. Raynaud's, where there's vasoconstriction in the digits, often in cold weather, can occur spontaneously. It's very common. There's probably a bunch of people in the room who have it, and it can be normal in many cases, but can also be a sign of autoimmune disease. This is sclerodactyly, seen in scleroderma or systemic sclerosis, with loss of the soft tissue on the fingertips, tightening of the skin, pitting of the skin, and digital ulcers. All right. And we listen to the lungs. As I said, crackles are very common. Can I turn the lights down so you can see this? Is that okay? Okay. You guys know which button I press? This one? Okay. So have you guys gone through a CAT scan, like a normal CAT scan? Good with that? Should we do that? Yes, we should do it? Okay. Lights are okay? All right. So the funny thing about a CAT scan is it's hard to orient unless you know what you're looking at. So I would imagine, so I know some of you know this, but just imagine I had an orange in my hand and I cut the orange in half and you're looking at the inside of the orange. So this is a cut through a patient and you're looking at the inside of the patient. What's the orientation? Well, when you get a CAT scan, they're laying on their back. So their body is literally out here in space. They're laying on their back. Their feet are pointing at that wall, and their head is behind the screen. And this is a slice through their neck up here. So we're kind of looking up at them while they're laying on their back. This is the back, front of the body, right shoulder, left shoulder, and they're laying on their back. You're looking up at them. Does that make sense? That's the trachea. And it looks dark because it's full of air. And air looks dark on a CAT scan or an X-ray. For example, all this air out here is actually part of the scan, so it looks dark. So healthy lungs ought to be dark because they're full of air. And we do most of these CAT scans, we do it full inspiration. So when you see things that are not perfectly dark, then you worry that they're either going to be blood vessels, which are normal, or they could be inflammation or fluid or scar tissue or something that increases the attenuation of the X-ray beam. So we're now go slice by slice down through the lungs or above the lungs. Let's come down, 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 down. Here we go. So here's the top of the lungs, upper lobes, and that's normal. Those branching white structures, if you can see them, are just blood vessels. They're normal. We'll come down some more. Here you can see an airway kind of heading in a caudal direction. Coming down more. All that lung tissue, so that's a nodule. All of that lung tissue looks pretty good. There's a little bit abnormal there. We just ignore that. That's why it's in quotes, normal in quotes. But it's normal enough for us. Okay, it's hard to find a normal CAT scan. All right, so that's normal. You saw all that dark, healthy, air-filled tissue with some branching blood vessels. Okay, so let's look at another CAT scan. So here's something we call ground glass. Let me show it to you. So we're going to do the same orientation. You can see how thin these slices are. I'm going to bring it down a little bit more. There's some asymmetry, some volume loss on the right. Whoops, sorry. All right. So what we're seeing here is, and I do this with patients all the time, is I show them their CAT scan. And the first thing I usually do is I try to show them healthy lung. It's a little bit hard to find some healthy lung, but I would say that's probably some healthy lung in there. This is healthy lung up here. Because if you say that's healthy, then you start to look over here and you realize that's not good. It's not normal. So it is hazy here, hazy. It is hazy here, and here and here. So that haziness is called ground glass. Ground glass refers to the appearance of the lung on CT, sometimes on X-ray, but typically on CT, where we can still make out the architecture of the lung underneath. We can see blood vessels or septal lines, but it's hazier than it ought to be. And so ground glass is very common in people with interstitial lung disease. Look how much there is. How much there is. There's actually a lot of scarring on this, which I'm not going to focus on. I just want you to focus on that haziness. So that ground glass could mean a lot of things. That just means that there's extra stuff there. It doesn't tell you what it is. It could be fluid in someone with pulmonary edema. It could be infection in someone with bronchopneumonia or pneumonia. It could be inflammation in someone with interstitial lung disease. It could be a lot of things. In this case, it is inflammation in someone with interstitial lung disease. Ground glass. Good? Okay. Here, something we call reticular opacities. You probably learned that reticulation or reticular opacities are a bunch of intersecting lines on a CAT scan. So we're going to come down again. Let's hope it works. Uh-oh, not working. 2 out of 3 is not bad. Yeah, sorry. But I have it over here. Okay. So here again, these are just 3 different images. Ground glass, so normal here, hazy here, ground glass. Ground glass signifies inflammation if they have interstitial lung disease. Could also be fluid, other things. Reticulation is over here. See all these intersecting lines here? Meshwork almost? That's reticulation. And that typically means fibrosis. And I keep hedging a little bit because you really need to look under a microscope to know for sure. You need a biopsy or an explant or an autopsy specimen. But in most cases, that's what that means. And then honeycombing refers to thick-walled linear cysts. That means end-stage fibrosis. Good? So here are a few examples. Drug-induced interstitial disease, and we don't need to go over all of these, but I'll point out amiodarone causing this consolidation. You see that airway? See that branching airway? So that branching airway is called an air bronchogram. Have you heard that term? Air bronchogram means that you see all of this white stuff around it, outlining kind of a negative image of the airway. And you see that air bronchogram because all of the alveoli around it are full of something. And when you have full alveoli with air bronchograms, we call that consolidation, which is different than ground glass. This would be an example of ground glass, although it's mixed with another pattern. This would be hazy ground glass. Can you guys see how that white is more dense? So that's consolidation. It means air spaces are full of something that's not air. Nitrofurantoin, please don't prescribe it. Dr. Gordon's going to be angry with me for saying that. Methotrexate, chemotherapy, these can all affect the lungs. Systemic sclerosis, dermatomyositis, rheumatoid arthritis. So you can see here all this hazy ground glass, patchy ground glass, honeycombing. Pneumoconiosis, silicosis from sandblasting and other exposures, causing a micronodular pattern. Asbestos can cause fibrosis with pleural plaques, borreliosis that dental technicians get, not dental hygienists, dental technicians get, can be pretty awful. A couple patients with that. Those are just meant to be illustrative of what interstitial lung disease can look like in different settings. So we go through that CRP approach, history, physical, serology, CAT scan, and often a biopsy. We'll talk more about biopsies. Biopsy is, again, in about 30 to 50% of the time, very helpful in making a diagnosis because often we can't figure it out without the biopsy. We prefer to do surgical lung biopsies done thoracoscopically if a patient is a suitable candidate for surgery because we get multiple pieces of the lung from multiple lobes on one side to give us kind of a widespread impression of what's happening in the lung. There are other ways to do biopsies. You guys learn about bronchoscopy? No. So a bronchoscope is like, a bronchoscopy is like a colonoscopy for the lungs, but the scope is bigger than the one we use for colonoscopy. Just kidding. Smaller. So, wow. So we go through the mouth or the nose, down into the lungs. through the larynx. And we can look around and do washings and do biopsies of the lung. Those are called the transbronchial lung biopsy when we try to sample the lung tissue. Those pieces of lung that we get from a transbronchial lung biopsy are quite small and often are not helpful in sorting out what's going on in this disease, but can be extremely helpful in other conditions like infection and cancer and other things. I'm going to talk a little bit about management in the second hour, but the mainstays of management for all patients, and I put it on this slide because it's so important, is adequate supplemental oxygen use. Many of our patients are very limited and have poor quality of life because they're not using enough oxygen and they desaturate. So as soon as they try to leave the house, they're out of breath. So they are miserable. And by using more oxygen, or more than they think they need, they can actually do a lot more than they think they can. And then pulmonary rehabilitation is an exercise program that is critically important for many patients with advanced lung disease. Okay. And then treatment, I think I'm going faster than I thought I would. Treatment, in addition to the things I've said, number one is we try to find a trigger and get rid of it. So if it's hypersensitivity to pneumonitis due to birds or mold, we get the birds out of the home, or get the person out of the home, get the mold out of the home, or get the person out of the home. If it's from a drug, we try to get them off that drug if possible. If they have an autoimmune disease, we try to treat that. If they have a lot of lung inflammation, then we treat their underlying inflammatory disease, or we can simply use corticosteroids or other anti-inflammatory or immunomodulatory therapy like mycophenolate or azathioprine to try to treat the inflammation in the lungs. That, of course, can have side effects. There are some antifibrotic therapies that are now FDA approved. They were approved in October, so this is the first time I'm giving this lecture and talking about these as approved therapies. They're called pirfenidone and nintedanib, and I'm going to talk about them in a little more detail. And of course, we also use lung transplantation. You probably haven't heard a lot about lung transplantation. There are about 2,000 lung transplants performed per year in the United States. That's not a lot. It's about the same as the number of heart transplants, but pales in comparison to all of the kidney and liver transplants that occur. So there are 2,000 a year, but there's 100,000 people with pulmonary fibrosis, millions of COPD, 30,000 cystic fibrosis. So a huge shortage. Most people will not get a lung transplant if they need it. About 800 to 1,000 of those transplants are performed for pulmonary fibrosis. So we're, yes, it can be helpful for those who can get it, but most will never get one. So you guys have seen a slide like this, right? Yes. Yes? Okay. So this is simply that summary slide for you so that you have all the components of the physiology, diagnosis, and treatment that influences different components of the physiology. Cool. All right, so I finished a little bit early. Maybe should we start the first case, Alan? Yeah? Okay. So you guys want to do the break now? Is that okay? And then start a little early? Or is that bad? That's good? Okay, so it's 42, 43, so let's start at 53 on that clock, okay? Good? All right, thank you.
Well, it depends on what's going on, right? Recently, so there's always a reason. So it can be an abnormal picture, like a lot of work that you may or may not see the nodule or vessel circumference is on. That is not so common. The people who have ARDS, whose alveoli are fluid, they may still be perfused. So you have the oxygenated blood going to these very distinct alveoli that you don't get to see.
An antibiotic or medication is one use
It can. There's two parts to it. So people who have interstitial lung disease from another cause can get worse if they take overdose or many people in that breakdown have repeated courses or are in long-term nowadays it's more like repeated courses. And it's like the recommendation.
We're going to start in 1 minute.
I think most of you saw, but the slides are in Courseworks or on Oasis now, so you can log on and get them. Sorry for the delay.
Okay. Can you guys hear me in the back? Yes? We're good? All right. So why don't we get started again? We're going to take you through, hopefully get through 3 cases to give some context and then fill in missing pieces of information. We'll do a little clinical pathologic correlation here. So this is the first case, an actual patient of mine. At the time was 54 and came to see, I guess, you, because he has been short of breath for 2 years, first while mowing his lawn, then became more dyspneic than his wife while they would exercise side by side on treadmills in the gym. And by the time he came to see me, more dyspneic with activities just around his home. So, and this is a very typical history of someone with interstitial lung disease. It would be unusual for that to be asthma, right? Asthma is more like an episodic, it can be exertional in nature, but maybe not progressive over time. Had a dry cough, meaning no sputum, had some joint pains, and of course, as soon as he told me about the joint pains, I'm thinking about autoimmune diseases like rheumatoid arthritis. No wheezing, no hemoptysis, no fevers or chills. I asked him about cardiovascular issues. I asked him about some autoimmune phenomena that were all otherwise negative. And he says, well, I do have osteoarthritis. So the rheumatoid arthritis idea kind of faded away in my mind. Hypercholesterolemia, and I asked him very specifically, have you ever had cancer? Have you ever had chemotherapy? Have you ever had radiation therapy? Do you have any eye problems, any skin problems? Have you ever had any connective tissue disease? Have you ever had tuberculosis or any other prior lung disease? Kind of standard questions I would ask in this setting. I asked him about medications. He told me he took Simvastatin, multivitamin, and acetaminophen. But I also asked him, have you ever had chemotherapy, amiodarone, methylphenidate, or other chronic medications that you don't currently take right now? Right? Because I want to get more information. He said no. Then I asked him, anyone in your family ever have anything like this, or any lung disease, or any scarring in the lungs, or any inflammation in the lungs? Anyone ever have autoimmune diseases like lupus, scleroderma, rheumatoid arthritis, myositis, Sjogren's? That's actually how I say it to patients, and I use my fingers like that. Seriously. And really important, has anyone ever used oxygen at home? Maybe a distant family member, maybe towards the end of their life. Oh, your uncle did. How old was he? He was 50. Well, it's probably not end-stage COPD at age 50. Could be, but unlikely. Did that person ever smoke? No, he didn't smoke. Why was he on oxygen? We don't really know, and he died shortly after. Well, that might have been pulmonary fibrosis or interstitial lung disease. I asked him about his smoking. I asked him about alcohol and drugs. I asked him about birds and humidifiers and hot tubs and forced air heating. I asked him about his jobs. And we have a questionnaire that we use in the office to ask about all of these things. We have him fill it out beforehand so we make sure we don't forget anything. And all of these little occupational exposures have been linked to different interstitial lung diseases. So then I examined him. He was a little tachycardic and tachypnic and actually had a low-grade fever. I think that turned out to be nothing, but that was true. His saturation, oxyhemoglobin saturation, was 94%, breathing room air at rest. And then I walked him in the hall, which is we all kind of do all the time for our patients, and he desaturated from 94 to 90. So 94 alone is abnormal, right? But he's likely hypoxemic. And 94 down to 90, a change of 3 or 4 percentage points, is also abnormal. So he had some desaturation. He had no jugular venous distension. His chest was symmetric. He had no accessory muscle use. He had bibasilar crackles, which I heard halfway up. And no wheezes or rhonchi. His heart exam was normal and no cyanosis or other changes. So here is pulmonary function testing, which would be one of the next things I would have ordered, or usually they walk in with it in their hand. So, should we go through it? You're comfortable with it, right? You feel solid on this, right? Okay. So let's start with the first line of the spirometry. So we have 4 things here. We have spirometry, lung volumes, we have diffusion, and we have an arterial blood gas. So let's start with spirometry. The FVC, the amount of gas that he could blow out during a forced expiration after a maximal inhalation, was supposed to be 4.6 liters, 4.5 liters. That's what he should have been able to do. but he was only able to do 2.9 liters, which is 65% of 4.5. So would you say that his forced vital capacity is low? Reduced? Fair, yes. Okay. So what are the possible explanations for that? There's only three. So one is he could have a restricted ventilatory defect, and we'll look at the lung volumes in a moment to see if that's true. What else could be possible? What's that? So he could have some kind of gas trapping from some kind of airflow obstruction. So we're going to look at the rest of his spirometry in a moment to see if that might be the case. And what's the third possibility?
Muscular problem.
Yes, good. So a muscular problem, or they didn't try very hard. Right? You take a deep breath in, and you blow out as hard and fast as you can, and not as much air came out as you expected. So assuming your expectation was correct, it usually is, then either there wasn't a lot of air in there to begin with, or they didn't try really hard to get it out, or they couldn't get it out, they couldn't get it all out because it got trapped in there. Right? I mean, that's just like logic, right? Those are the three things we just said. So it's one of those things. Then the FEV1 is 63% of predicted, and the FEV1 to FVC ratio is 78%. So does he have airflow obstruction? Raise your hand if he has airflow obstruction. Raise your hand if you think he doesn't have airflow obstruction. Good. I think the people with their hands up are right. There's no airflow obstruction because the ratio is over 0.7. If you guys teach the lower limit of normal, or you teach the 0.7? 0.7. Good. And then he says all these other numbers that you want to try to forget about and ignore. I don't know, do you guys teach the other numbers? Like FEF 2575.
We believe it to them.
Okay. So they refer to, they signify something going on in the airways. They are measures of airflow during the middle or end of expiration. And one of them looks a couple look a little bit down, 61%. I see a 44% for the FEF 75. So it makes you wonder about the gas trapping thing. But then you can jump down to your lung volumes and decide if there's a restricted ventilatory defect. So how would you know if there's a restricted ventilatory defect? What value would you look at? Total lung capacity. Good. And the total lung capacity should have been 6.5 liters, and it was only 4.5 liters, which is 68% of 6.5 liters. So that's kind of low, too. So he does have a restricted ventilatory defect, right? So are you guys comfortable with that? That's the logic to go through that. So there's a restricted ventilatory defect without without airflow obstruction. Good.
Is the cutoff for TLC 70 as well?
Yes?
Well, for this course, yes.
For this course, yes. Okay. So we'll skip a couple other things, but we'll go down to the diffusion. You guys learned about DLCO, right? Carbon monoxide diffusion in 10 seconds. So DLCO should have been 33.6 mLs per millimeter of mercury per minute, and it was only 10.7, which is 32% predicted. And that means what? Means that diffusion impairment is diffusion abnormality is a cause of impaired gas exchange? No. So that's the weird thing. So when the DLCO is low, it doesn't mean that a diffusion abnormality is present and responsible for impairment of gas exchange. In fact, if you were to find that there's an elevated AA gradient, then you could not conclude that the diffusion abnormality is responsible for it just because DLCO is low. I know it seems paradoxical, right? Did I just blow your minds? You guys still recovering? Right? Okay. Yeah, that's true. Because you can have an impairment in diffusion without that actually being responsible for your impairment in gas exchange, which I know is also hard to swallow. So here's the blood gas. Breathing room air, 21% FiO2. pH is 7.43, PCO2 of 36, PO2 of 69. What ventilatory disorder is present, if any? How many people say none? How many people say impaired gas exchange? How many people say hypoxemia? How many people say alveolar hyperventilation? How many people say alveolar hypoventilation? Abstain. Okay. So the answer is alveolar hyperventilation because the arterial PCO2 is a little bit low, but it's very mild. Alveolar hyperventilation. Is hypoxemia present? Yes? Yes? Is hypoxemia present? Who say yes? PO2 is 69? Yeah, so that's an easy one. Right? So hypoxemia is a low arterial PO2. Do you teach under 90 or 100 or something like that? Okay. And then I'm not asking you to calculate the A gradient here because you've done it and you'll do it again. Here it is given to you, and it is 38. Is that normal? No. It's high. Can you tell from this set of PFTs why it is high? You cannot. You cannot. Just because the LCO is low doesn't mean diffusion abnormality is the cause. It is not. You have to know what the disease is pathologically and what the pathophysiology of that disease is, and then deduce what the causes of impaired gas exchange are. Okay. So we did a 6-minute walk. We needed 2 liters by nasal cannula to maintain a SAT of 96%. This is just at rest to bring him up to 96. He was able to walk over 1,000 feet, which is not so good. We'd all walk at a normal pace, probably 2,000 feet or more, in 6 minutes. And he desaturated on those 2 liters from 96 to 87. So this is bad that he needed some oxygen. That's a bad sign in and of itself. And the fact that he's desaturated is also bad. So I'm going to introduce a new term to you. It's called usual interstitial pneumonia. And it unfortunately refers to 2 different things. It can refer to the appearance of the lung on a CAT scan, a high-res CAT scan. It can also refer to a lung pattern that Dr. Borzuk is about to talk to you about. And while they can agree sometimes, that is, the same person can have a usual interstitial pneumonia pattern on the CAT scan and on their biopsy of their lung, it doesn't always agree. But this is the typical pattern that we see in the lung of someone who has a disease called idiopathic pulmonary fibrosis, which is what this person has had. Here in this single axial CT image, you can see lots of normal healthy lung, more towards the center, kind of the core, so to speak, of the lung. Whereas at the periphery, around the pleura, just under the pleura, it's very abnormal. And what I see are lots of intersecting lines, reticulation. See that? And then over here, I see a line, kind of linear collection of thick-walled cysts. We call that honeycombing. And we think that's the end stage of this more early reticular change. But typically, classically, the reticulation and the honeycombing are both thought to be fibrosis or scar tissue. And in idiopathic pulmonary fibrosis, on a CAT scan, we usually see peripheral, meaning subpleural, honeycombing and reticulation. That's worse in the lower lobes and not as bad in the upper lobes. That's the very classic pattern that you see. Here you can't tell upper from lower because it's an axial cut. Okay. I mentioned this, 2 different patterns, the high-res pattern, and then you're going to hear about the histopathologic pattern. Okay. So this disease now is called idiopathic pulmonary fibrosis, or IPF. It's the most common of the idiopathic interstitial pneumonias. It is defined histopathologically by usual interstitial pneumonia, and it is idiopathic, meaning we don't really understand the cause, although a number of risk factors have been identified, including older age, male gender, cigarette smoking, family history. And I'm going to let Dr. Borzuk discuss with you the pathology of the disease. You want to use this?
So, after being involved in this course for many years and seeing it evolve, it's occurred to me that we spend the first few days of the course showing you how everything is inside, normal and abnormal. And then we move on to suddenly having to think about the fact that we really need to look at patients from the outside in, and that in reality you very rarely get a chance to see what's on the inside. And that's good, but it's also bad because you're using surrogates for many of the pathology findings when you're doing that. You're using physiology, you're using imaging, some things are structural, some things are not. And the terms oftentimes begin to overlap. People use those associations synonymously, which is why you have a UIP pattern by radiology that doesn't exactly match a UIP pattern histologically because the pattern seen radiologically is associated with the pathology, but that association is imperfect. But nevertheless, that is the easiest and fastest way, non-invasive way, and you can see as Dr. Leder talks, he goes from talking to a patient, which is the least invasive in some way, to biopsy, and which would be the most invasive, but other things in between are somewhat invasive, and you have to then judge an arterial blood gas doesn't tickle, and so you have to think about those things as well. From a pathology point of view, though, we see the radiology image of honeycomb lung, and we see these spaces that are part of that honeycomb appearance. Again, the thought is that you look at a honeycomb, and these are rigid structures with spaces, right? They're not floppy plastic bags. And so that's why honeycomb, someone came up with this idea. But actually, in many ways, it doesn't particularly look like a honeycomb. In fact, many of the spaces that you're seeing here are actually going to be bigger than the spaces that I'm going to show you on the gross pathology. Because what you're really seeing is this radial traction on airways, this traction bronchiectasis. These are airways that are being held open, in contrast to emphysema, where the airways collapse because of loss of that radial traction. In fibrosis, the radial traction creates rigidity in the lung. So when we look at it histologically, you could look at that section and say, well, where's the honeycomb? And that's okay. Because in fact, for us, microscopic honeycombing is a somewhat different phenomenon. What I'm showing you here is that the disease has this interesting feature of having large areas of spared lung, and then within the lobule, at the periphery, there's fibrosis. And this is a fairly early section from a biopsy showing that the fibrosis does seem to have a distribution at the periphery of the lobule, and that there's an eradication of normal alveolar spaces replaced by fibrosis. Again, normal or relatively normal lung, and the UIP fibrotic lung here from an explanted lung, and you had examples of this in your lab. Again, showing that a lot of what's being seen radiographically as honeycomb lung is in fact these markedly opened air spaces, but that actually these other areas really don't particularly look like honeycombing. They just look like large tan white broad areas, and all of this represents scarring. When you look at the pleural surface, you can actually see nodularity on the pleural surface, almost like a nodular liver of cirrhosis. And again, this is because areas of fibrosis contract the tissue. The collagen causes contraction. And so you have sort of spared areas and contracted areas, and that gives that nodularity. When we take a closer look, again, all of these are areas of fibrosis. All of this represents lung tissue that no longer has any alveolar architecture whatsoever, and what's left behind really are just the structural elements of the conducting airway, as we discussed in the histology, as opposed to normal lung next door. When we take a closer look at an area where there is at least some preservation of lung tissue, the red areas represent spared areas, and again we start seeing, even grossly, the peripheral nature within the pulmonary lobule of the fibrosis. It has a pattern to it, for sure. When we then convert that gross appearance to the histology, we can see the spared areas with alveolar walls being fairly thin and maintained without really a lot of inflammation. And that would correspond to an area like this, where we have the spared area. But if we look at the edge between the spared area and the dense scarred area, we localize to an area histologically that's like this. And then if we look at the spared area versus the scarred area, we see that there are areas in the yellow where there's really no recognizable alveolar lung parenchyma at all. It's just one large scarred area with just these dilated spaces as airways. When we see this pattern, regardless of whether there's large airway traction, this is the pattern of usual interstitial pneumonia. Spared lung, densely scarred lung, a relative paucity of inflammation, and when we look at normal alveoli and we look at scarred areas, some of the scarred areas can have a few inflammatory cells in them, but that's okay. It's mostly scar. When we look at the alveolar walls themselves, the alveoli are still recognizable in the spared areas. But at the interface, and let me just take you back here, at the interface between the spared and the scarred lung, we find foci of fibroblastic proliferation. And it's felt that these fibroblastic foci represent the active part of the disease. So the active part of the disease is not inflammatory. It's a fibroblastic proliferation. There are folks who have made this akin to a model of wound healing of some kind. But that the injury is unknown, and that it is progressive, unfortunately. And eventually, that gross honeycombing that is corresponding to that traction appearance on the CT scan can lead to histologic changes that are corresponding, which are these dilated air spaces. And this is the honeycomb lung that's being described. Again, area of scarred, spared lung next door. So the pathology has summarized that you have spared and densely fibrotic lungs side by side, that active fibroblastic proliferation is thought to be the advancing front of the disease, that the areas of spared lung are being progressively replaced by fibrosis, and that these fibroblasts and myofibroblasts are the source of that collagen, that there's alveolar remodeling, and that you get functional alveoli getting progressively replaced to these honeycombed areas, which really are just scar. The honeycombing itself, the spaces, are just conducting airways. They don't have any gas exchange function. And that, in general, this type of scarring is irreversibly injured, and that this is really the progression to fibrosis is difficult to halt to begin with, but once it's there, it's not reversed. And so lung compliance in these lungs is decreased. Volume changes, pressure changes do not result in much change in volume. You can see why volume is decreased. The alveolar zones are largely replaced. Airways do remain open. Ventilation is unevenly affected, and you can see why now, both grossly and microscopically. The diffusion reduction and the defect elicited by exercise, you can see by the thickening of the alveolar walls, and that this is a restrictive disease. Now, I just want to make a point about this, because while this is a disease that remains a highly fatal disease, or certainly a disease that leads to organ failure, what I just showed you in the pathology is really key to understanding why the therapeutic approaches that you're going to hear from Dr. Lederer have been thought about. 15 years ago, we didn't really think about the disease in the way we think about it now. And certainly one strategy initially was really to protect the lung that is not yet scarred, to slow that progression and to not do anything more to injure it, because it is still functional. The next phase is to try to halt whatever's going on in that fibroblastic focus, the environment there, and to reverse that progression. And the third ideal would be to actually reverse the fibrosis. But in fact, that's the hardest task, and it's not clear that that's going to be easily accomplished. I want to say that because one thing I want to leave you with is that this is a frontier of medicine right now. And the pathology explains it a lot in terms of why it has the appearance it has, why it's such a challenging disease. But I would posit to you that when you see a CT scan with honeycomb lung, that's a little different than the microscopic honeycombing, but more importantly, all those areas of honeycombing represent fibrosis, they represent irreversible fibrosis, and the ball game's over in those areas. That's not something that you want to reach. You want to avoid that at all costs, and that's going to be the key to this disease. Anyway, with that, I turn it back over to Dr. Lederer.
Thank you. So we have our patient. You have an understanding of the pathology here. Often in the office, and this kind of ties into that clinical radiologic pathologic correlation, we go through the following type of algorithm. We might suspect someone might have IPF. We search for identifiable causes through history, physical, serologies. We do the CAT scan. Maybe it has that UIP pattern, in which case we could make a diagnosis of IPF. If it has, I'm not going to go into the details here, but if it has some other type of pattern, we might then perform a surgical lung biopsy, which would then tell us whether or not it is IPF or not IPF. Let's skip that. The survival in this disease is quite poor. Most patients only survive a few years following diagnosis. This is a little bit outdated. It's from 2001. The survival is not too much better now, but it is about the same. So the median survival time is about 3 years. That's for all comers. But there's a long period of symptoms before the diagnosis is made. The median survival time now is maybe closer to 4 years, but still quite poor. And most people die from either an acute worsening and what might look like ARDS-type picture, or from chronic slow progression. The management, and we've talked about a number of these things, risk factor reduction, I'm kind of broadening this to ILD a little bit to make it more generalizable. Risk factor reduction, we've talked about oxygen therapy, pulmonary rehab, age-appropriate vaccination. I promptly treat infections in these patients. Drug therapy that I'll mention, and I've already talked about lung transplantation. So there have been many clinical trials trying to find treatments for idiopathic pulmonary fibrosis, and as I alluded to, until 2014, we had no FDA-approved therapies. One of the early thoughts was that immunosuppression might help, and I'll mention that on this slide. Another early theory was that antioxidant therapy might help, and as it turns out, neither of those approaches work for idiopathic pulmonary fibrosis. The National Institutes of Health sponsored a large clinical trial called the PANTHER IPF trial, which was a 3-arm randomized clinical trial for folks with mild to moderate IPF. One arm was given prednisone with azathioprine, which is an anti-metabolite, and N-acetylcysteine, or NAC, which is an antioxidant. Another arm was given NAC alone, and another arm was given placebo. And this strategy was thought up so that they could study the antioxidant compared to placebo, and they could study this combination of immunosuppression and an antioxidant to placebo. And about 3 or 4 years ago, this arm, the triple therapy arm, was stopped because of harm. And what they found when they compared the people receiving prednisone and these other medications to placebo was an increased rate of death, respiratory death, hospitalization, acute exacerbation, and serious adverse events. This is not insignificant. This is a 7-fold increase in mortality. That's a risk ratio of 7, which was surprising to some. This had been standard therapy in Europe for many, many years and was used by many doctors in the U.S. because many pulmonologists said, I have nothing to give my patient. I have to try something. And it turns out that what many doctors were trying was harmful. So following this, practice changed considerably. I'll tell you that NAC also did not work. It wasn't harmful, but didn't work. But fortunately, 2 other drugs have been shown to work. So the first drug is called pirfenidone. It's pictured here. It's a small non-peptide molecule, and it has a variety of in vivo and in vitro effects. There's a lot of uncertainty about which of these effects is the therapeutic effect in IPF, but it does inhibit release of pro-inflammatory cytokines from fibroblasts. It attenuates fibroblast proliferation, inhibits release of transforming growth factor beta-1, and inhibits collagen synthesis, as well as some other effects. So it has anti-inflammatory and anti-fibrotic effects. And it's been studied in 3 large phase 3 clinical trials that were based in the US but were multinational. One of those early trials indicated that it slowed progression of IPF. A second trial was equivocal, and the FDA decided not to approve pirfenidone until a 3rd trial was completed, which is the results of which are pictured here. This trial, which was the ASCEND trial of pirfenidone for IPF, enrolled 555 adults with IPF. They were randomized 1-to-1 to receive pirfenidone, which is it's a big dose. It's about 2,400 milligrams, 2,400 milligrams a day. Pirfenidone by mouth or placebo by mouth for 1 year, and the primary endpoint was the change in lung function, change in FVC, and we're all familiar with. And as we've talked about, FVC is a measure of lung compliance. Fibrosis influences lung compliance, and so if we see that in the placebo group there's a rate of progression here of losing about 400 cc's of lung volume over a year, and people who took pirfenidone only lost about 200, that would be great. And the p-value is not here, but it was a significant effect. And pirfenidone also had beneficial effects on changes in 6-minute walk distance and a suggestion on an improvement in mortality. So based on that, the FDA approved pirfenidone to treat IPF, and it was approved in October. So we're still on the learning curve of learning how to use it, but many patients are now on it. The second drug is nintedanib, a larger molecule pictured here. It's a growth factor tyrosine kinase inhibitor, inhibits VEGF, FGF, PDGF. It was developed as an anti-cancer agent, but also found to have potentially have anti-fibrotic activity through these, presumably through these pathways. And very similar to pirfenidone, nintedanib also slows progression. This is change in FVC. Here's the placebo group declining over a year. Here's the treatment group declining over a year. And based on this trial, these two trials actually of nintedanib, it was also approved back in October. And so in contrast to every other year for the past 8 years I've been teaching this course, we now have 2 drugs to treat idiopathic pulmonary fibrosis, a disease 2 of you heard about before today. Okay. That actually is quite common. So any questions about IPF? Yes?
Are there any anticipated sort of wound healing or other fibrosis-related consequences of those drugs?
Yes. Nintedanib is, there's a lot of concern about wound healing in nintedanib. And for example, people who are actively listed for lung transplantation are taken off of nintedanib so that when they do get transplanted, it's not hanging around. But pirfenidone, there's been no concern or risk with that. That's a very good question. Yes?
Have there been any trials where the two drugs have been used concurrently?
Ooh, that's a good one. So have there been trials where they studied both drugs together? The answer is no, not yet. There's a lot of interest in that. There's a report, it's not a clinical trial, but a report out of Japan that was just published within the past few months in the European Respiratory Journal. I'm getting 2 mics going here, right? Can you still hear me? Yeah. Where they took people who were prescribed pirfenidone and then given nintedanib, not a clinical trial, just clinically. And it seemed to be well tolerated, and there were no serious pharmacokinetic or drug interactions, things like that. But there's a lot of interest in that, and it probably will happen pretty soon. Okay, so we have 2 other cases we're going to try to get through. Case 2 is a different kind of interstitial disease. Again, same chief complaint. Again, this is a real case. 32-year-old patient of mine who at the time, this is actually before I met him, as historical history, 3 months at the time of new exertional dyspnea in association with persistent dry cough, sounds familiar. And he had been evaluated for fever, weight loss, joint pains, a rash in his legs a few years back. The rash looked like this. It's called erythema nodosum, tender paniculitis focally around there. And he had a chest x-ray at the time, which showed bilateral hilar lymphadenopathy. Does anyone know where the hilar lymphadenopathy is? Anyone point it out? You guys are rough. Come on, green arrow sign. So this is the patient. This is normal. This is the green arrow sign with hilar lymphadenopathy here. All right. Sorry. Okay. So at that time, when he presented with that fever, joint pains, rash, hilar lymphadenopathy, he was given a diagnosis, and he was treated with ibuprofen, and things got better. Now, his dyspnea and cough nowadays is accompanied by fatigue, occasional chills and night sweats a few times a week, no recorded fevers. He does have some swelling around his ankles and a new rash on his face. I'm going to show you the picture. It's not him in the picture. It's from a publication. But a new rash on his face. He's lost a little bit of weight, no hemoptysis or chest pain. Here's the rash. Oh, sorry. Rash is coming. He has some obstructive sleep apnea. He's obese. He had a hernia repair in the past. No current medications. Ibuprofen was back when he had those early symptoms. No drug allergies. Mother has diabetes. Father had cirrhosis. No family history of lung disease. Never smoked. No alcohol. No drug use. He's a chef. And all of that exposure history is negative. On exam, you see his vitals there. His tachycardic tachypneic. Saturation at rest was 90%. Mild respiratory distress, something we've been talking about in small group, and we'll talk more about. Purple plaques on his nose and face that I'll show you. No jugular venous distension. He had scant, very scant basilar crackles. No rhonchi or wheeze. S1 was normal. He had a loud P2, which was regular. No murmur, rubber gallop. Abdomen was fine. No edema or clubbing. I think this is, yeah. So again, this is not him. This is from a New England Journal publication. But the rash in his face was lupus pernio, these purple plaques on the nose and face. So what disease does he have? It's lupus, right? No. Sorry, it's too easy. Doesn't have lupus. So that's just what the rash is called. So his pulmonary function tests are here. His FVC is 44% predicted. So either he's got restriction or gas trapping or poor effort. His FEV1 is also low. And his FEV1 FVC ratio is low. It's 53%. So he actually does have airflow obstruction. As I said, typically, if you go back to slide 4 in the slide deck, typically no airflow obstruction, but some people do. And this is one of the diseases where they can have some airflow obstruction. But look, he also has restriction. So he has a combined restrictive and obstructive ventilatory defect. His DLCO is 24% predicted, so that's low. And his blood gas shows a pH of 7.42, PCO2 48, PO2 62, breathing room air. So he has a little bit of alveolar hypoventilation, right? And he has, it's good. And he has hypoxemia because his PO2 is low. Good. So here's his current chest X-ray. Remember that old chest X-ray with the green arrow sign? So here's his current chest X-ray, very abnormal. Would you say this disease is worse on the right, worse on the left, or similar on both sides? Similar, so it's symmetric. Would you say it's more in the upper zones of the lungs or more in the lower zones of the lungs, or similar? Upper, lower. Upper? Upper? Good. Would you say, how would you describe this? Would you say it's kind of hazy with some extra lines? Yeah. And maybe there's some cystic change here, right? You're not sure what that is? And maybe there's fullness here. So all of those things actually would be reasonable ways of describing what you're seeing, which would be different than saying this person has pulmonary edema, or this person has pulmonary venous congestion, or this person has interstitial lung disease, because you shouldn't really conclude those things from an X-ray, but you can describe what you see. I see kind of bilateral symmetric upper lobe haziness with extra lines and cystic change. That wasn't that hard, right? Okay. So this is what he has. He has a disease called sarcoidosis. And I've described different phenotypes of the disease along the way. Not all patients have all of the things that I've said, but it's important to note that this is a disease that doesn't just affect the lungs, it can affect any part of the body, and it is a granulomatous disease. The inflammation, as you'll see, is granulomatous. Generally thought to be of unknown cause unless there's a recent discovery. No, okay. There are some infectious diseases and genetic causes that have been identified and postulated. It occurs worldwide. In northern European countries, we have the highest incidence around the world. In the U.S., black Americans have the highest risk and typically have more chronic and severe disease. And I'm going to turn it over to Dr. Borza to get some pathology.
And so case 1 was an example of replacement of the alveolar walls and interstitium with fibrosis. And so case 2 is an example of the same, but now with inflammation. And in this case, the inflammation is histiocytic in the form of granulomas. And this certainly summarizes the disease as an idiopathic disease of unknown cause, again, with the hyaluradenopathy and interstitial disease, although, as shown in the case presentation, it can be systemic as well. The histology of the disease is very similar in organs involved, whether lung or other organs. And while normal alveoli, same picture has been repeated, here the interstitium will develop these nodules histologically. They're nodular aggregates of histiocytic cells, and well-formed versus poorly formed granulomas is something pathologists sort of throw around as a term. When they're distinct nodules of histiocytic cells like this, we'll say that they're well-formed, and when the histiocytes themselves look more polygonal than spindly, we'll sometimes use the term epithelioid histiocytes, and clusters of epithelioid histiocytes like this are granulomas, and you won't find a definition of what a poorly formed or well-formed granuloma is, so you can use my definition, which is 5 histiocytes is a granuloma. And so that would be a poorly formed one because it's only 5. When you have large aggregates like this that are too numerous to count, they're well formed. And again, most of the time in sarcoidosis, and that's going to be in contrast to case 3, the granulomas are devoid of other inflammatory cells, or at least there are very few of them. So it's really predominantly a granulomatous process without much other inflammatory component. Here within this well-formed granuloma, again epithelioid histiocytes, there are aggregates of multinucleated cells or syncytia of the histiocytes, and because they're giant, we call them giant cells. Of course, both Dr. Lederer and I are discovering the difficulty with our deadpan delivery of comedy. But it's okay. If we really thought that we could do that for a living, why would we be doing this? There you go. So the importance of this disease, in contrast to the first one, is that the histiocytic collections or granulomas are an inflammatory condition that actually can come and go and remit sometimes spontaneously, but also can be induced to remit with therapy as opposed to fibrosis, which really does not resolve and does not remit. Most patients do recover, but one of the important take-home messages of this case is that, you know, everything that we do in medicine, and especially in pathology, is in a way to try to make a prediction about what's going to happen. So in case one, we see the fibroblastic proliferation, we see the fibrosis and the destruction of the lung that's occurred, and we're making a prediction based upon our experience with other patients that that is not going to stop, and that it's going to continue to the point of organ failure, and that we're going to try to stop it with medication, but we know that that's going to be difficult even with modern meds. In sarcoid, we have a different situation. We see that histology, and we're making a prediction that most likely it's going to get better. Okay? However, there are a subset of patients who will progress to fibrosis with sarcoidosis, and that fibrosis, it will also be irreversible and could end in organ failure. It just happens in a lower proportion of cases, so the prediction would be better than in the first case.
Thank you. So, building on that, sarcoidosis, as we said, can affect different organs in the body. This is from a series. I'm sorry that the reference is not showing up there, but from a large multi-center case control study. In the initial manifestations of the disease at the time of diagnosis, 95% of folks had some kind of lung involvement, either interstitial lung disease or, less commonly, pulmonary hypertension. Skin can be involved about a quarter of the time. Lupus pernio, which is not lupus, just what you saw, and erythema nodosum, 2 rashes that you saw. Lymphadenopathy, eye involvement with uveitis, liver involvement, which is typically asymptomatic and probably is at much higher prevalence than 12% in an asymptomatic fashion. Uncommonly, spleen involvement, neurologic involvement of a variety of both central and peripheral types, hypercalcemia, probably due to vitamin D overproduction, and in some cases cardiac involvement. This low prevalence is probably misleading because many patients do develop subclinical or even clinical conduction abnormalities, which could be life-threatening. So this is from a nice New England Review. It's amazing to me that this is now old because I remember the older one that then got outdated by this one. But these are a couple of typical cutaneous manifestations. Skin plaques, lupus pernio that you saw, uveitis, which is this redness. This synechiae is this change in the iris. Enlarged lacrimal gland, endobronchial cobblestoning. So what you're looking at here is actually a bronchoscopic view of the trachea. So imagine you were standing on the posterior wall of the trachea facing the feet. You did that in your head. And you're looking at the carina. That's the carina. It's the right main and left main bronchus. And the cobblestoning it's hard to appreciate. I'm sure maybe it's better on your screens, the lumpy appearance there. Very typical when we do a bronchoscopy. We see that. That's almost always going to be sarcoid. And we can do little endobronchial biopsies and see granulomas in there. And here this person had facial nerve involvement with palsy on one side. So patients who show up with sarcoidosis definitely need a little bit of extra evaluation beyond the typical ILD patients. Beyond the typical stuff we might do, we'd certainly do an EKG and an echo. I actually do that for all my ILD patients, but we'd certainly be looking for any cardiac involvement, make sure they see an eye doctor and a dermatologist. We do liver and kidney tests, calcium testing. And then we don't usually do this unless there's a reason, but things like PET imaging, MRI, to help localize active disease outside the lung, CT imaging can be helpful, but is actually not required in all patients depending on what the X-ray appears, how the X-ray looks. Now, you will come across something called different stages of sarcoidosis. And this, you will also hear that it is misleading, that these are not stages, and that is true. They are not stages. It does not progress from stage 1 to stage 2 to stage 3 to stage 4, and whoever came up with that nomenclature many years ago did us a disservice, because patients show up saying, I have stage 4 sarcoidosis, or stage 3 sarcoidosis, and that doesn't necessarily correlate with much at all, except the appearance of an x-ray. So I will tell you that stage 1 is that first x-ray I showed you with hilar lymphadenopathy, but the lungs are not involved. Stage 2 is a combination of lung involvement, parenchymal involvement, ILD, and hilar lymphadenopathy. Stage 3 is no hilar lymphadenopathy, but there is interstitial disease. And stage 4 are the people who are very sick with fibrosis and often have upper lobe honeycombing and these other classic CT changes. But again, people do not typically progress through the 4 stages. They can have any particular stage, and it can go backwards too, although if you have advanced fibrosis, it usually doesn't go away. But I've certainly seen people with stage 2 and 3 get much better. So not really stage is not the right term. Here's a typical appearance of the lungs in someone with sarcoidosis. This is a coronal CT image. It looks almost like a chest x-ray, right? But it's a CT image. And I chose it because it illustrates a few nice concepts. Mostly that the disease is not necessarily lower lobe predominant, like IPF would be, but can be mid-lung or upper lung predominant. And it typically is around the hyla of the lung. And often when fibrosis results, and that's a band of fibrosis there, it often pulls the hyla outward and upward, the very typical classic appearance in sarcoidosis. So as I said, we don't understand why people get sarcoidosis. It is thought that there's some persistent antigen, whether that's an autoantigen or an external antigen. No one really knows. I'm assuming it's probably a little bit of both and some cross-reactivity, but I don't think anyone knows. But some autoreactive T cells develop, forming these granulomas, and in sometimes it resolves, and sometimes it does not. Treatment is complicated, and we don't need to go into details. Many people with sarcoid don't need treatment. They can be followed over time if they have mild disease without, say, cardiac or neurological involvement. Mild little bit of lung disease could be followed without treatment. But people who have more advanced disease or people who progress will often need prednisone. And sometimes they need long courses of prednisone, but we do try to get them off of prednisone over time. And again, as opposed to IPF, which often is relentlessly progressive over the course of a few years, this is a highly variable disease. Some people have it for decades, and it can cause minimal impairment, whereas others have more serious disease and ultimately need a lung transplant. So I'm going to move to the third case, and we're going to try to do it in the 10 minutes or so. Is that the clock we use, or this one? Okay. That we use to present the last case, the third case. Bear with us. So no surprise, the chief complaint is dyspnea on exertion, the teaching point. This is a 58-year-old man who was well until 6 months ago when he started to develop dyspnea every time he exercised, and that was new. Before that, he was okay exercising. He does have dry daily cough. Again, it seems repetitive, but this is every patient who comes to see me. No fever, sputum, hemoptysis, chest pain, weight loss, some knee pain. He snores. Review system is otherwise negative. He has coronary disease and hyperlipidemia. Here is medications, no allergens. No family history of lung disease, the smoking, he's a 12-pack-year smoker, and no other exposures. Oh, except that he breeds pigeons in his backyard. True story. 94% on room air. He's obese. He has crackles on exam. Otherwise, his exam was pretty unremarkable. Oh, sorry, he had acrocyanosis. Okay. He had pulmonary function testing with a very modest reduction in FVC, almost in the normal range, really, without airflow obstruction. He did have a mild, borderline, I would say, normal to borderline low TLC, and a low DLCO, 34% predicted. Mild alveolar hyperventilation, right, because that's a little low. Pretty severe hypoxemia, PO2 of 57, breathing remain. 6-minute walk test, desaturated on 4 liters after walking 1,600 feet. Desaturation is seen in interstitial disease, is seen in pulmonary hypertensives, and can be seen in people with other airspace filling disease, but they're usually really quite young. So most of the time, this is interstitial disease when they desaturate. Here's an example of a CAT scan. I don't think this is his CAT scan, but this is a good example of a CAT scan. Remember in idiopathic pulmonary fibrosis, the disease was all around the pleura, subpleural? Well, this is not. This is in the center. This is like diffusely throughout the lung. And in here, I almost get the sense that it's kind of around the airways. Look at that. See that? Almost like a tree, only leaves on the tree of these branches. Does that ring true to you? So that bronchovascular distribution of disease, which is not necessarily the same bronchovascular distribution you would see microscopically, although it can correlate, this is not typically seen in idiopathic pulmonary fibrosis. It's seen in other types of interstitial disease, maybe even due to something you're breathing in. We sent off a lot of rheumatologic serologies. They were negative. I looked for eosinophilic types of lung disease. Didn't have that. He did have circulating precipitating antibodies to pigeons. Now, these are blood tests that simply tell us about exposure. We already knew about the exposure because he told us, so that was no surprise. It would have been more surprising if it was negative, right? And the disease that he ultimately had was a disease called hypersensitivity pneumonitis, which I see a lot of. Now, this is an inflammatory and fibrotic, and it could actually be on one extreme or the other, interstitial disease due to an immunologic response to an inhaled organic antigen. The most common ones are birds, more commonly fungi like Aspergillus and Thermophilic actinomyces. Some bacteria like Mycobacterium avium complex, and even some chemicals, isocyanates, which can cause occupational forms of asthma, have also been linked to this, although I wonder if there's some overlap. So this is a list that you're responsible for in your exam. All right, now we're getting it. All right. So this is a list of different forms of hypersensitivity pneumonitis that have been reported in the literature, the antigen responsible, and the source. And it's actually quite humorous if you go through it. There's farmer's lung, which is not too surprising. There's also mushroom worker's lung, and malt worker's lung, and cheese washer's lung. That's the worst job. Sauna taker's lung, seriously, hot tubs can do this. And wood trimmer's lung. And now, here's the interesting thing, is that there's a second page. So, and if you look, and go back to the first page, if you look, these are mostly molds, different forms of mold, but also birds in there. And then some chemicals down here. So, and this is from, again, I'm sorry about the reference not being there, but this is Bible printer's lung. You don't want that. Okay. So here's the interesting thing. Lots of people are exposed to these things all the time. There's very few exposed people who actually develop the disease. So it's not just the exposure. It's the exposure in the right setting, maybe with other environmental exposures, but also probably with genetic factors. And there are some links to HLA types, to an antigen processing gene polymorphism, TNF-alpha polymorphism. There's actually a link between HB and not smoking, which is weird. I'm not sure I believe it, and I never tell that to patients, so don't tell it to patients because then they want to smoke. Humoral immunity may play a role, and there's a lot of thought about that because we test for these circulating antibodies that show exposure, but probably it's cell-mediated immunity, as you'll see from the pathology in a second. So we often will make a clinical diagnosis based on the presentation, the history of the exposure. Maybe they have antibodies or at least have known exposure, restricted ventilatory defect, a certain pattern on the CT that we talked a little bit about. And then in many cases, we'll get a biopsy.
So as you gather from the case presentations, there's a lot of overlap in these presentations. And we sometimes say that we're often rounding up the usual suspects in these cases, and oftentimes very difficult to ascribe a cause to a lung disease. And this is an example where it's not idiopathic. At least we have an understanding of the pathogenesis of the disease. And so this is an immunologically mediated disease. It involves the part of the airway that is the most distal part of the conducting airway and the respiratory zone. In that part of the airway, it's important to realize that the immunoglobulin that's present is IgG, not IgE. The large airways, bronchi, nasal passages, you can start at the nasal passages going to the bronchi. That's mostly IgE is the immunoglobulin that's present there, and also IgA. And so when we talk about hypersensitivity in the larger airways, we're often talking about IgE-mediated diseases, and we're talking about eosinophils, we're talking about that mast cells. But in the distal part of the airway, when we're using the term hypersensitivity, we're actually talking about an IgG and cell-mediated type of immunity. And that's an important distinction Because in other organs and in other settings, you're going to hear hypersensitivity and think about IgE and eosinophils. And that's true in the lung, but not in this part of the lung. So again, what we see pathologically is we do see a bronchiolitis. The small airways do develop a lymphocytic predominant bronchiolitis with lymphocytes and plasma cells. There will be inflammation in the interstitium, and so there is alveolar wall thickening. And both in the airway and in the interstitium, we'll see histiocytic collections of poorly formed granulomas. And so again, a normal bronchiole. Here a bronchiole infiltrated with lymphocytes and plasma cells, a lymphocytic or chronic bronchiolitis. Even here, you start seeing these little patches of cells which turn out to also be poorly formed granulomas. In the interstitium, you will find lymphocytes and plasma cells, again causing widening, and it's hard to take a picture of it without there being a granuloma in the field. But here, focusing on the granulomas, again, not as well formed as the ones in sarcoid. They're not big nodules. They're more collections of some giant cells, sometimes only histiocytic cells, 5 to 10 histiocytic cells in an aggregate. And so this is, again, the combination of a type 3 and type 4 hypersensitivity or cell-mediated hypersensitivity. And so in the cellular cases, the alveolar wall thickening is due to inflammation, and that is potentially reversible. Avoiding the antigen, it can be responsive to steroids. The challenge here is that while we understand the cause of the disease to some degree, we don't understand why patients have different responses to these antigens. And more importantly, once they've had a response to the antigen, we don't understand why a subset of patients, and unfortunately a fairly substantial subset, will develop fibrosis. And unfortunately, the fibrosis, again, is irreversible. And unfortunately, sometimes progressive even with antigen exposure, avoidance, and steroid therapy. And so fibrosis in this disease has the same problem. It happens with some frequency. And unfortunately, it happens in some patients even subclinically, so that the point of presentation, they already have quite a bit of fibrosis, and the disease has already taken up a lot of their lung parenchyma with fibrosis.
Hear me okay? I think this is actually the last slide. So treatment, as you just heard, includes antigen avoidance, which can be expensive because sometimes it means mold remediation from someone's home or moving that person out of their home. Sometimes it's mold in the workplace. The bird issue is quite challenging because many people will not even tell us about the birds. I had a patient where on the third visit, we were having to talk about, well, we need to do a biopsy because I really don't know what you have. And his wife finally made him tell me about the birds he keeps. So, and I know that sounds funny, and I've been making these dry humor jokes, but that's kind of serious. So it is a big deal. The immunosuppression can be extremely helpful. I've seen some people have dramatic responses, but many don't respond. And then, as you heard, one transplantation. So that's it. Thank you for your patience, and we'll do a small group.
Anyone have any questions for either Dr. Korshuk or Dr. Levin?
Any questions? I'll hang out up here for a few minutes. Yeah.
Establish the diagnosis that it's a reaction to some stimulus, some like antigen? Do you do an IgG test for something specific? I mean, that seems pretty, like, how do you know what to focus in on? Is it based on their history?
A lot of it's based on the history. So part of it is figuring out if they do have hypersensitivity pneumonitis first. That's based on the CT appearance and other clues, biopsy maybe. And then to figure out if it is hypersensitivity, what's the cause, we definitely do a panel of IgG serologies, the circulating precipitating antibodies to different molds and birds and feathers and things. And sometimes it points us in a direction, but sometimes it doesn't. And so in many circumstances, it's asking the right questions about what they're exposed to. For example, I had a patient where we asked all these questions about her home. She wasn't working. Nothing in her home sounded like there was going to be mold there until we found out she had a summer home. And the summer home had a mold problem. And then we said, well, go, have your home checked for mold. And they found a lot of mold, and they got rid of it. And so that probably was the cause. Can I say 100% that it was? No, but probably.
So I'm just trying to parse out, how do you tell the difference exactly between like idiopathic fibrosis versus fibrosis from something else?
Most lung doctors are not good at it.
Okay.
So it is a challenge, and that's kind of why we don't teach it, because it's a lot. We just did 2 hours and we talked about 3 conditions and gave you a general overview. So it is a very challenging field. It's a combination. It's kind of that CRP thing I said. It's a combination of getting the right historical information, being carefully attentive to the clues on the physical exam, the right serologic testing, which is often not done, doing the CAT scan the right way so we can see what the pattern is, and then integrating all of that information together. And about 50 to 70% of the time, we'll say, this is idiopathic pulmonary fibrosis, or this is hypersensitivity pneumonitis, or you actually have rheumatoid arthritis, and that's why you have lung disease. And then the rest of the time, we can't figure it out, and we try to get a biopsy done if they're a surgical candidate for a biopsy, because then we can integrate the biopsy with all the other information. In some diseases, like cancer, the biopsy is the diagnosis. But in this, the biopsy is a key part of it, but it's not the diagnosis. It's part of the whole picture. We can have one person, two people with very similar biopsy appearances, but have 2 different diseases or from 2 different risk factors.
And what's the origin of the name sarcoidosis?
I don't know.
Do you have any idea? I was just curious, like, what that meant. If that means.
Yeah, that's a good question. I don't know.
Okay, just
yeah,
curious.
sure.
Thank you.